So a little bit about me. I think it's important to know the person that's presenting. So, I'm a urologist here with Advanced Urology. My specialty is men's health, sexual health, but primarily quality of life improvement. And so what I do, and the reason I went into what I do is because, you have your urologists and your surgeons that help take care of cancers. And when the cancer care is done and you're over that, or let's say you have diabetes or you have your doctors that take care of any of these comorbidities, when that care is done, oftentimes you're sort of forgotten about. And I'm the doctor that takes care of the stuff that most people forget about, which is the quality of life aftercare. And so, what I love doing is improving things like sexual function, invigorating or returning that intimacy that was lost, improving your urinary function, improving your the number of times you go to the bathroom, if you have any leaking, all these things that impact your quality of life but get forgotten or thrown under the rug. And I probably get more gratification from what I do than any other surgeon out there, just because I see the after effects and the benefits, and the patients really feel the difference. And so I really, really, really enjoy what I do. I did my training I went to undergrad at the University of Florida, probably the greatest university on the planet. I did my medical school training up in Ohio. I did do some time at Johns Hopkins. I did some research over there. I did my surgical training or my urologic training at the University of South Florida, which is really one of the premier men's health centers in the world. And we have, one of the top, if not the top, andrologist or men's health prosthetic surgeon, who I think exists over there, Dr. Raphael Carrion. And so, I'm very well trained in what I do. I love what I do. And today, I guess you'll get a feel for some of the things that we would talk about if you were to come to my clinic. Okay, so today's agenda. Today's focus is going to be on erectile dysfunction. A couple things to keep in mind when we talk about treating erectile dysfunction. It is sort of erectile dysfunction is caused by a bunch of different disorders, conditions. They oftentimes are related, and we'll talk about some of those relationships. But prostate cancer treatments, heart disease, enlarged prostate, all of these are interconnected with erectile dysfunction. At the very end of the talk, one of my patients, just an awesome guy who went through a lot of these treatments, will kind of tell you his story and what he went through and how he got to where he got to. And then you'll have an opportunity to ask a bunch of questions, and I'm going to do my best to answer all of them. So what is erectile dysfunction? Erectile dysfunction, the book definition is the consistent inability to sustain an erection sufficient for sexual intercourse. So what does that mean? Any inability or change in your ability to either have an erection, keep an erection, or sustain an erection enough to have sufficient sex is erectile dysfunction. So if you were able to keep an erection for, an hour, no problem, and now you can only keep it for 30 minutes, and that's bothersome, and that's impacting your relationship, well, then that's erectile dysfunction, okay? So, in general, any change or inability to have a sufficient erection, or what you consider a sufficient erection, can be considered erectile dysfunction. There are approximately 30 million men in America that have erectile dysfunction. That's 1 in 4 men experience erectile dysfunction. And we'll talk about the different forms of erectile dysfunction. But so you're not alone. So just keep that in mind. But I'll tell you, men are not good at addressing health concerns. And they're especially not good when it comes to sexual dysfunction. And I'll tell you, most women are a lot more vocal and and take a lot better care of themselves. And so that's why men's health is not a super prominent thing, because men are just not good at going to the doctor. And women are a lot better. And so a lot of the men that come to me come because their significant other made them come, and it's appreciated and they appreciate it, and ultimately they're very happy about it. But so anybody that showed up to this talk, I appreciate it because I know it's not that easy to do. Okay, so research has shown that greater than 80% of men suffering from ED can trace it to a physical problem or disorder. And we're going to talk about that. We're going to talk a little bit about psychologic ED versus a physical or organic ED. And those are physical conditions that could be contributing. And we're going to go through a lot of these, okay? Erectile dysfunction can also be a marker for early heart disease. And the reason is because a lot of erectile dysfunction is caused because of blockages in blood vessels. And when you have underlying heart disease, the first blood vessels that get clogged are the small blood vessels. And a lot of those blood vessels are the blood vessels to the penis. The bigger blood vessels, like the ones to the heart, tend to come later. And so oftentimes, erectile dysfunction can be a surrogate marker for heart disease. And so a lot of my patients, if I have concern for heart disease or some of the workup shows blockages in vessels, I may have you see a cardiologist. So other risk factors, aging. Aging itself is not really a risk factor per se, but with aging comes a lot of comorbidities, high blood pressure, high blood pressure, heart disease, diabetes, stress. If you've had years of smoking, years of alcohol abuse, all these things over time play a role, and all these things over time tend to increase your risk of heart disease. And anything that increases your risk of heart disease will increase your risk of erectile dysfunction. So remember, those two things are very, very interconnected. So, we talked a little bit about aging, and like I said, with aging comes a lot of stress and a lot of medical conditions. There's diabetes, there's high blood pressure. Those are two very, very, very important risk factors, and probably two of the more common ones, all right? With diabetes, the worse your sugars are controlled, the higher the likelihood that you can have erectile dysfunction. And there are three primary causes of erectile dysfunction. There is a fourth called psychogenic, but three organic causes. Either blockages in blood vessels, something we call venous leak, where the blood can go into the penis but leaks right back out, so you can't sustain the erection, or a nerve problem. And diabetes can contribute to all three, all right? It's probably one of the only conditions that contributes to all three. So it is really, really important that you keep your sugars under control. The more uncontrolled your sugars are, the faster you're going to get erectile dysfunction. With blood pressure, if you have increased pressure, it does increase your risk of forming plaque formation, all right, and blockages. But even more so when you're on a blood pressure medication, what happens is your blood vessels are used to having this high pressure, and then all of a sudden you drop it. And when you drop your blood pressure, you're dropping the flow in your arteries. And when you drop the flow in your arteries, you're decreasing flow to the penis. And so a lot of the treatments for high blood pressure can also contribute to erectile dysfunction. So this is an important chart because it kind of summarizes a lot of the high risk factors, right? So diabetes, 4 times risk of ED, the highest you're going to have. Prostate disease, so enlarged prostate in itself can cause erectile dysfunction. Even more so if you have prostate cancer and you've been treated for prostate cancer, that treatment is a very, very, very common cause of erectile dysfunction. Peripheral vascular disease, so anything that clogs blood vessels, heart disease. We talked about high cholesterol, which increases your risk of heart disease, and high blood pressure. Okay, and we talked about those. Those all give you about 2 times or double the risk of heart disease, of erectile dysfunction. Someone mentioned the hardest part of going to the doctor's office, I'm reading straight off the chat group, is the fear of hearing bad news, but also customer service can be terrible. My experience is I sit around a lot, and when I'm in a business and my health is an issue, it seems as though my time is not valued. If I set an appointment for 10 a.m., I may not see a doctor till 10:30, or if best by 10:45. What do you do to make sure you're meeting the timelines of the appointments are scheduled? If I sit in your office, am I going to see the phone ring and no one respond? That is something I see and have experienced. I think that's a very reasonable statement. Very reasonable statement. So here's what I'll tell you. It's hard for me to predict how long it's going to take to see a patient. Okay, we have time slots. We try to predict it the best we can. We try to get patients in the same as fast as we can. But there's also a lot of little things that get done in the process. We get your vitals checked. We make sure that there aren't other things going on. We check your urination. We make sure you're emptying your bladder. We check a lot of different aspects. I won't lie. There are times when patients are waiting 2 hours to see me. Most of the time not, but that does happen. And the reason is because every single patient that I see, I will give them the full amount of time they need. I have never had a patient tell me that when they saw me, they did not get enough time with me, okay? And that's the one thing that I promise them. So if you waited a long time to see me, I promise you, you'll at least get all the time that you need to see me. All right, and that's the only promise I can give you, because I can't promise you that clinic won't run late. I try my best to see everyone on time, but I think that's something important to keep in mind. And I tell every patient, look, I may spend a lot of time because some patients end up needing more time than expected, but when your turn comes, you will get all the time you need. All right, so going back to this, more risk factors. All right, prostate cancer. So prostate cancer treatment is one of the most common causes. Diabetes probably number one, and this is probably number two for causes of erectile dysfunction. And that's because, let's say we remove your prostate. Well, the nerves for the erections actually run around the prostate. So when we remove the prostate, they get injured in the process. We also tie off blood vessels down in the pelvis so that you don't bleed during the surgery. And a lot of those blood vessels are also blood vessels that improve your erections or contribute to your erections. Radiation obliterates blood vessels, okay, and it hurts nerves as well. So those things impact your blood flow. Smoking and medications. The medications, it's primarily high blood pressure, okay, and we talked about those. They decrease your blood flow, and thus they can cause erectile dysfunction. Smoking doubles your risk of erectile dysfunction, and that's because it's another risk factor for heart disease. So if you ever need a reason to stop smoking, that's probably as good as any. So one thing you can do to help yourself: stop smoking, eat a healthy diet, a heart healthy diet, and those things alone will at least not hurt you, if not improve things along the way. Okay, so how do erections occur? Well, everything starts with stimulation. So your brain, you have to have excitement, you have to have somebody or something stimulating you. When you have stimulation, you have to have the drive to have an erection. The thing that contributes to your drive primarily is testosterone. So one of the things that we oftentimes check is testosterone. If you tell me, I am able to have an erection, but I just don't have the libido or the sex drive, well, it could be low testosterone. So that's one of the things we check. Next, your brain sends a signal when you're stimulated to the nerves saying, hey, listen, give me some nitric oxide. And when nitric oxide is released by the nerves, blood vessels enlarge or engorge with blood, and those blood vessels, when they engorge with blood, they cause blood to flow into the penis, and that's how you get an erection. Okay, and so you can see right here the blood kind of filling these two natural channels inside the penis, and then when they're full, that's when you get an erection. Okay, one thing you'll also notice that on the outside, see over here and over here, on the outside of these channels are little veins, okay? And I don't know if it's as clear here, but when these channels engorge with blood, what happens is they squeeze these veins shut. And what happens when they don't squeeze those veins shut is the blood leaks right back through those veins and out, and you can't sustain an erection. So when these engorge properly, they will squeeze those veins shut. If you have a half erection, so some people say, I ask them, hey, does when I take a PDE5 inhibitor, I get half an erection, so it kind of works. And what I tell them is, look, if you have a half erection, it's as good as having no erection. And the reason is because you don't block off these veins. And if you can't block off these veins, then, and the veins are right here, okay, and right here are these blue things. And if you can't block off these veins, then you will lose your erection very quickly, okay? So that's great. And everybody says, that's awesome. Thank you for filling me in on that. But I'm really here to know what you can do to fix it. And so that's what we're going to talk about. Okay. Everything starts with oral drugs, right? Anybody that comes in, the first thing we're going to do is the least invasive thing you could possibly do, which is start some oral medications. Now, there are some people who can't have oral medications, particularly if you're on a medication called nitrates for chest pain. And if you're on that medication, then you're automatically contraindicated to get this. These medications, you've probably heard of them: Viagra, Cialis, Levitra, Stendra, Staxin. All these medications, what they do is they increase nitric oxide and improve blood flow. Okay, there are side effects from these, and so there are a lot of patients who just can't tolerate the side effects. These include headaches, flushing, changes in vision, upset stomach, muscle pains. And so there are patients, and some people get gastric burning. So there are patients who get these side effects and they just don't tolerate them. There are a couple other problems with this. Number one is it's sort of like a Band-Aid, right? You take a medication, you hope it works in an hour or two, but sometimes the time that's right to have sex is not in an hour or two, but maybe in 10 minutes. You're trying to pop a pill last minute, it's not working in time. The other problem is that they can be very expensive. These pills can cost, especially if you get the brand version, they can cost up to $200 or $300 a pill, which is crazy, right? You can now get the generic version for cheaper. Okay, but even those versions, they tend to cost money. I mean, it's going to cost you somewhere around 30, 50, 60 bucks a month. And, if you're paying that much money to have sex, it's almost like prostitution. Every time you have sex, you have to pull out a buck, right? So, in that sense, it's not always the best option, but it is worth trying. And a lot of patients do benefit from it. And if you do, awesome, and that's all you need, well, great. We'll continue that, and until you need to do more, I'm content, you're content, and everyone's happy. For patients that need to do more, then all the other options come into play, and I would call them all about equal as far as which one to start and which one not to. And let's go through all the risks and benefits of all these options. One option is the penile injection therapy. The way this works is you get an injection into the side of your penis, and then usually within about 10 to 15 minutes, you'll get an erection. There are downsides to this. If it doesn't work, it can be a frustrating process because you're sitting there with the needle trying to inject yourself. If you have to travel somewhere, then you take these needles with you, which can be a pain to do. It can sometimes kind of kill the mood if you're saying, hey, I want to have sex, but just give me a minute because I want to stick a needle in my penis. It does require some degree of training, but the number one negative to this is you can get an erection that lasts too long. And yes, that is a thing. You can get an erection that lasts too long. And if that happens, you could end up in the ER. And so if you go too fast, too quick, you could end up in the ER. And in that case, they take large bore needles, put it into your penis, and try to drain the blood out, which can be very traumatizing. Okay. The one thing that I do is I have 100% of my patients try this, but in clinic, for two reasons. Number one is when I do an ultrasound to look at the blood flow pattern, so I understand why you have erectile dysfunction, I need you to have an active erection. This is how I induce it. But there's a benefit to you. Number one, you get to see if you even tolerate or like putting injections in your penis. Number two, I get to document whether you liked it or tolerated it, but also how you responded. So we can see if you actually even respond to it. And number three, if it's something you want to consider, we can dose you appropriately to try to prevent that risk of priapism, okay, or an erection that lasts too long. Vacuums have their role. I'll tell you, erections are not necessarily the number one role. Now, the way the vacuum works is you put a cylinder over the penis, you press a button, or you hand pump it. The suction effect will pull blood into the penis, and then you try to slide a rubber band off the cylinder to the base of the penis to hold it in. Here's the problem with the rubber band. If you've ever had a rubber band around your finger, it's going to turn blue and clammy. And that's the kind of the effect that you can have with the penis. It also tends to cut off ejaculation. So if you ejaculated before, it kind of squeezes that urethra, and so you may not see much come out. The other problem is it's kind of a pain to use. It's hard to sometimes get a seal, and then when you try to slide that rubber band off, oftentimes you lose the erection. So it's not the greatest for erections, but I'll tell you what it is good at. It's good at bringing or restoring that muscle atrophy. So there's something called disuse atrophy, where if you haven't had sex for a long time or you haven't had good erections for a long time, what happens is the penis muscle just kind of loses its strength. It's just like someone like me who has scrawny arms because I haven't worked out for a long time. The penis becomes scrawny as well. And this is a great way to kind of rebuild that muscle. And so oftentimes, even before surgery, I'll have patients use it if they're concerned about length or girth, because it really, really, really improves that. And I've seen great results from that aspect, okay? So there is a role for that. Erectile dysfunction, not necessarily one of them, but it does have a role there as well. There are something called urethral suppositories or urethral gels. And, this is kind of like the injections, but you don't have to stick a needle into your penis. Instead, you stick an applicator into that channel that you pee out of, and then you kind of rub the penis for about a minute, and that stuff gets absorbed. The biggest negative is it does cause burning. The second biggest negative is it's expensive for a very small amount of medication, and it's not nearly as effective as the injections. Now, for patients that do awesome on the injections, for those patients, and then they do okay on the meds, it's a nice middle ground. And oftentimes I'll have patients take it with the meds. And so that is one of the benefits of it. But the groin pain is one of the big negatives. And I'll tell you, this is one of the most discontinued treatment options, partly for the price, but also because of the burning. All right, then we go down to surgery. And let me see, we have a few questions here. Let me quickly answer them. So is it best to check testosterone in the mornings? Yes, the best time is in the mornings because that's when your testosterone is supposed to peak. So if it's supposed to peak and it's low, that's called low testosterone. At the end of the day, it's generally always low. And so if it's supposed to be low and it is low, well, it doesn't tell me much information. So that's why we always check it in the morning. Is there a particular age erectile dysfunction can occur? The older you get, the higher the risk of erectile dysfunction. In fact, I think every year that you're older, your testosterone drops about 1%, but your risk of erectile dysfunction also goes up. There is no such thing as too early or too late, and the reason is but younger guys tend to have more psychogenic components to their erectile dysfunction, and as you get older and the comorbidities increase, then you tend to have more organic or physical components to your erectile dysfunction. Can the penis reduce in size? Yes. So the longer you go without having good erections, you will slowly start getting that disuse atrophy, but those channels that are not sufficiently filling with blood will slowly start losing length and size, and they'll start contracting, and they'll start forming scar tissue. So yes, if you don't have sufficient blood flow for a long, long time, you will slowly start reducing penis size. And so when they say, if you don't use it, you lose it, it's true. I mean, that's a fact, okay? All right, so now when it comes to surgery, which is, I think, an excellent option, all right, and it's as equivalent to all those other treatment options that we talked about. There are two types, okay? There's the malleables and the inflatables. The malleables, think of these as your Toyota implants, the Toyota of penile implants, all right? They are reliable, they're durable, they're usable, people like them, okay? But they're not very technologically savvy. They're easy to use. The best part about them is that they're always up and they're always ready to go. And the worst thing about them is that they're always up and they're always ready to go. And so, if you have grandkids and they jump on your lap often, it can get a little awkward with these things. And so that's where the negative comes in. But they're easy to put in, they're quicker to put in. The recovery time, I'd say, is about the same, maybe about a week quicker. They're more cost effective if you're paying out of pocket. They're totally concealed, you can't see them at all. They're basically rods that go inside of those two natural channels that I showed you earlier inside the penis, and they go in there and they're always up. You can bend them up, you can bend them down, you can bend them in any direction, but it stays firm all the time. Okay. The next option is inflatable, and think of these as the Lexus of penile implants. Okay, this is The more tech-savvy version, they're just as reliable. They are just as dependable. They're just as liked. In fact, liked a little bit more. The satisfaction rates are about 95% compared to 87%. But the biggest benefit is you have the control and the ability to inflate it and deflate it, to keep it up and keep it down whenever you want. So in that sense, it's a little bit more natural. It has more of a feel like a natural erection. These are also girthier and more rigid. So I can get more aggressive in sizing you because they're not an implant that's always up and causing pressure on the penis. And not only can I get more aggressive in sizing you, but they actually expand sideways. When you inflate them, they get girthier, and I can get more aggressive on putting a girthier implant. They do feel softer when they're flaccid compared to that because they're down, and then when they're inflated, they're a lot more rigid. So the rigidity is one of the bigger benefits of this as well. There are 3 components to this, and we'll talk about those components in now, actually. I'm going to show you a video, and I'm going to talk to you about all these components. Shelly, do you mind running that video? Okay, and so here is the Titan, and the Titan is one of my favorite penile implants. And so here you can see that there are cylinders inside the penis. There's a reservoir up there in the space areteus, which is a natural space in the belly. And there's a little pump in the scrotum. This whole thing is put in through one tiny 2-centimeter cut, all right, in the scrotum, sometimes above the penis. And right there, you can see, you can't actually see any of these components, but what you do is you learn to find that button, you squeeze it. When you squeeze it, the fluid fills these cylinders and gives you an erection. When you want to go down, you learn to find that button, you squeeze the button, you push on the penis with 2 hands, and you're back down, okay? And so you can see you have full control of your erections. You can have an erection whenever you want, and you can make the erection go away whenever you want. Now, this erection you can keep up for as long as you want. You can have sex for as long as you want. It almost makes you superhuman because you can have sex all night and all day, and there are not many guys that can say that, all right? You can keep this up for weeks and months and years if you really want to. So that's one of the benefits of this implant, okay? Here's the question: what is the best way to recommend this procedure for my partner? Well, it just depends. I would say the best way is to have them come talk to me or an expert in erectile dysfunction, because I would say that it's a lot easier for us to answer questions and from a more objective point of view. The one thing I'll tell you is, look, what this surgery will do, it's a team decision. It's going to be, this is a treatment that's going to improve intimacy for both you guys, all right? It is a treatment option that's minor. It takes me about 30 minutes to do. It's done as an outpatient. There's one tiny little cut. I give you a special, what I call a penile block. So I give you a numbing medication that lasts about 3 days so that you're generally pretty pain-free for those 3 days, okay? The recoveries are great. The risks are low, and we're going to talk about some of the risks. And it's really what most people really, really, really want. If they can't have spontaneous erections, because this really gets you to where you want to be. I mean, it gets you erections whenever you want. It does not affect your sensation, does not affect your orgasm, and does not affect your ejaculation. So if you're able to ejaculate before the surgery, you'll be able to ejaculate after the surgery. There are risks. There's a 1% risk of infection. I do a lot of maneuvers and things to reduce those risks. I give you special wash to use ahead of time. I use a special wash in the OR, then I do a special coating, and then I do something called a no-touch technique. There is a risk of erosions and migrations, and what that means is when you're healing, the implant can move slightly, and sometimes it's not in the perfect place, and we can do a minor surgery to correct that if we need to. And in rare instances, the implant can find its way out of the body, in which case, we let you heal and we put in a new one in. There is a rare risk of chronic pain, and if that happens, then there are ways we can reduce that, but it's not very common. In general, once you've healed and the pain's gone away, it stays away. And there is risk of device malfunctions. There is a mechanism to this, especially the inflatable one. There's tubings and things like that. So things can always break. In general, about 88% of people will have their implant will still be going strong at 10 years. So it has a pretty good long-term rate. Couple questions here. Let's see. The Titan can remain in indefinitely? Question mark. Yeah, it can remain in as long as you want. All right. You're not going to develop a resistance to it. Now it can break down, and if it breaks down, we may swap it out so that it can be functional. But in general, you're not going to develop some sort of resistance to it. If you have, I have heart disease and I'm nervous about getting this procedure. Is that high risk for me? Also have diabetes. I'll tell you, the majority of people that I put this in have heart disease and diabetes. That's why they have erectile dysfunction to begin with. And in fact, it is safer, in my opinion, than a lot of the medications, because the medications actually have more contraindications when it comes to taking them. Like if you're on nitrates, you can't really take the medications. The nice thing about the surgery is we always get a cardiac clearance, especially if you have heart disease or diabetes. We make sure that your heart is healthy enough to have the surgery. And, so we take every precaution possible before we actually move forward with it. So you're in safe hands. And I'll tell you that you're probably, if you have heart disease and diabetes, you're probably equal to about 80% of the patients that I treat. Can I still get pregnant? Yes. So this does not hurt one's ability to or one's fertility. If anything, it helps it because you can have better erections and you can have better sex. But it is not so it does not impact your ejaculation like we talked about. What if my partner can get a full erection but can't maintain it? So that is oftentimes something called venous leak. And remember, we talked about how the blood leaks back out through the veins. And that's something we check for when we do that injection and the ultrasound. When it comes to venous leak, it's tough to treat outside of the implant. The implant is really the #1 treatment for it. Now, sometimes you can use a ring or the rubber band with a vacuum, and that ring can constrict some of those veins and maybe hold it in a little longer. But I'll tell you, when it comes to venous leak, the #1 treatment is really a penile prosthesis, because no matter how good of blood flow I give you with all the other treatment options, it's going to leak back out. But that's a really great question, and I appreciate you asking that. Is the Titan check for health and safety on a regular basis? Yeah, it is. Listen, this thing is FDA approved. It's been around a long time, and it's very well regarded. So it is. I would say that it's a very safe procedure, and it's been through all the checks that you need. All right, insurance coverage. Let me tell you the best thing about the penile prosthesis. It is generally covered by most insurance plans, including Medicare, which is awesome. Okay. There are not many things in this world that are covered by almost all insurances. This is one of the few. So, one of the biggest concerns is always cost, and it is, it can be an expensive procedure, but it's covered by insurance. And so not just us, but even insurances realize that the importance of maintaining your ability to have erections, that's important. That's an important aspect of someone's life. And so they do cover it. And so that's something we could certainly look into. If you're interested in the surgery, we have our finance team that can certainly look into your insurance plan, and they can tell you, and they always do, they tell you if there's any out-of-pocket costs depending on your copays and deductibles, etc. Okay. All right. Additional things to know. So the implant also treats Peyronie's disease, which is bends in the penis. So we can correct that at the time. And there are other maneuvers we can do at the time of surgery that we can correct simultaneously. So for example, if you have incontinence where you're leaking, if you cough or sneeze, that's something we can either correct at the same time or correct before or after. There are also things like testicular implants that you can get information on, made by Coloplast. All right. A couple more questions. Let me see. If there's a malfunction, can you get it again? Yes. So if there's a malfunction, then we just swap it out. Great question. So we can just remove everything and put a brand new device in there. And I'll tell you, if you have an implant for long enough, 15, 20, 30 years, it's gonna malfunction if you're using it enough. And that's great. If you're using it enough to malfunction, that's awesome. I'm excited to change that thing out. How long before you can have intercourse after an implant? So I have this down to about 3 weeks, which is probably the fastest in the country. Okay, because any shorter than that, and you really haven't formed enough scar tissue to sustain intercourse. So I have it down to 3 weeks. Most people tell you 5 to 6 weeks, but because my cuts are so small, my patients have been healed by about 3 to 4 weeks. At 3 to 4 weeks, I teach you how to use it, and I give you the green light to use it. If I had a bend in my penis, which we call Peyronie's disease, that wasn't there a few years ago, will the implant fix that? It can. It can. And what I do is I check for that bend. If there's a bend, I mold it. Sometimes I have to do additional maneuvers like application or a patch graft. And based on the degree of bend, we talk about that ahead of time, and we can prepare for that if the molding by itself doesn't fix it. If you don't get full erections, can you get shrinkage over time? Remember, we talked about that. If you don't get good blood flow, even just partial erections, you can lose penile length. And one of the ways to preserve that length is to use a vacuum erection device. And I usually recommend using it 10 minutes a day, if not twice a day. And particularly before surgery, I try to get you to use it if there's any concern. If there's anything for us women who have lost interest, is there anything for us women? Absolutely. Absolutely. And a lot of women have low testosterone, and there are some other treatment options as well for women with loss of interest. And women have a sex drive just like men, and women actually have testosterone just like men. It's just a lot lower in levels. What a normal testosterone level for a male is about 500 or more. For a female, it's about 50. So, but a lot of women have testosterone that's much lower. Is there an in-office procedure? I'm not sure what that question is referring to, erections or low testosterone. But the testing is all in office. The surgery, prosthetics is outpatient, but in the ASC. We can do it in the surgery center, so it's safe and COVID-free. What if you didn't use an old one correctly? Can you give them private tips? Yes, absolutely. And so what I oftentimes do is I have patients, when they come to see me, I cycle the implant and I retrain them if I feel like that's necessary. So yeah, definitely, my goal is to just make sure that you're doing great. I don't care if I put the implant in or someone else did. I just want to make sure that you guys have a great, relationship and your intimacy is back, and whatever it takes to get you there, I'm happy to do. Okay, now what I'm going to do is I'm going to ask Richard, who, is just an awesome guy. He is one of my patients. He's gone through a lot of these treatment options that we talked about. So he's going to talk to you about his story a little bit, what he went through, the stresses that he went through, maybe some of the recovery. I'm going to give him a chance to talk right now. And then either he or I will answer any remaining questions that you have. I promise I'll get to all of them, okay? All right, Richard, if you don't mind taking over.
Thank you, sir. Thank you, Dr. Shah. Good evening. My name is Richard. I am one of the patient educators with Dr. Shah's office. And the reason I became a patient educator, I went through a lot of stuff that a lot of people are going to feel they're going to go through. I'm trying to give you a condensed version of my story. And if you have any questions, my number will be listed on the website. So you can call me anytime before surgery if you have some questions about the surgery, actually what you have to go through and everything. I'd be more than glad to answer. With me, I went through a lot of the things, almost everything Dr. Shah discussed. I went to a normal follow-up procedure for a checkup. I'm a healthy young man, 50-something years old. The only issue I had was I did have high blood pressure and I did have diabetes. Didn't think anything of it. I'm walking 8 to 10 miles a day. I was showing no symptoms of anything. Come to find out, I had a high PSA, which they check for prostate cancer. I went to advanced urology. Actually, I was seeing Dr. Shah's partner, Dr. Balani. He did a blood test, came back, my PSA was high. He said he thought I had prostate cancer. He said he wanted to do more tests. He did more tests. Come to find out, a week later, I found out I did have prostate cancer. This by itself was overwhelming. It devastated me. I didn't know what to do. He was talking to me. I didn't hear a word he said. All I heard was prostate cancer. He told me, he said, well, Richard, there's certain options we have. And he told me my options. So we decided to go and have surgery. September of 2018, I was diagnosed with cancer. October, actually 2 weeks later, I was having surgery to remove my prostate cancer. He told me the benefits of having the surgery, which would be erectile dysfunction, incontinence, some more things that probably will follow. But I went ahead with it. After the surgery was a success. I was laid up for probably 2 months, and I was recovering, but I could not have sex. Now, I was taking Viagra before the surgery. After the surgery, I had no erection. I couldn't get an erection. I don't care if whatever I did, I could not get an erection. I started taking more pills. I took Cialis, Viagra, Levitra, you name it, I took it. I was not getting an erection. So I go to Dr. Belani. I tell him, I say, look, this is not healthy. I need to have sex. I'm used to having sex before. Before my surgery, I was having sex 2 to 3 times a week with my wife. After the surgery, I couldn't even get an erection. So again, we went through the process of the medication. We tried the oral medication first. Did that for a few months. That didn't work. I was taking 2 pills, maybe 3 pills at a time, trying to get an erection because I was desperate. I could not get an erection. So then we decided to do the injection. The injection worked for a few weeks, but the problem, one of the issues I had was having an erection too long. And as Dr. Belani said, um, those injections, they're not good at all. For one, it was painful injecting myself. I was able to get past that, but before each injection, I had to pray, close my eyes, and then make sure I was injecting in the right place. That wasn't a good thing. Then once I did get an erection, the few times I did get an erection, it lasted too long. I remember my second time using it, I had an erection for 4 hours. And it was okay, but it started hurting. After 3 hours, it started hurting. Very painful. So then now I have to make a decision. What do I do? So I called the top line, and I called and talked to one of the nurses. She was like, well, you need to go to the hospital. Well, it was very embarrassing for me to go to a hospital and tell a young 30-something-year-old nurse that I have an erection that won't go down. I had to do it, and she looked at me kind of funny, which was okay. I'm in there. They bring out another needle to make to make the erection go down. It was not fun. So the fourth and fifth time, same thing. I would have erection from 4 hours, 6 hours, 8 hours. Very painful erection. I mean, this was like the skin was about to blow off. And I was like, I can't do this. I can't do this. So I talked to Dr. Belani again. He said, what you can do is an implant. We can do an implant. And he explained to me the different types of implants. And, I decided, well, we'll go with the implant. From day one, my wife was totally against it. Totally against it. She did not want the implant. She felt like, well, it'd be like a dildo, it'd be artificial and so forth. And knowledge is power, people. I will tell y'all, knowledge is power. She went online and she Googled all this stuff on implants. Well, we had an appointment with Dr. Shah. And Dr. Shah explained to me exactly what the implant were. He explained to me the different types, what options I had as far with the Titan, the Coloplast, and so forth. Well, I decided to go to Coloplast. Again, my wife was totally against this from day one. I brought her in to the doctor office, and he talked to her. The 3 of us, we decided she was still against it. I mean, but she couldn't understand what me as a man was going through because I'm used to having sex. And at an early age, men are taught that sex is everything. If you want a woman, make sure you can sex her down real good. If you can't sex a woman down, she's going to leave. So that's all I'm thinking. I'm not having sex with my wife. She's going to go someplace else. So fast forward, I had the surgery. My wife was still totally against it. It was to the point where I told her, either I have this implant and we continue our sexual life, or I'm gonna get a divorce. I mean, I need to have sex. I had a desire to want to have sex. Well, had the implant. At first, it was kind of bad because I was in pain for the first day, but it was more a psychological thing than anything. Me sitting on the bed right after the surgery, I'm noticing that my penis is bandaged and everything, and it just kind of freaked me out. But after about a week, I got in turn with it. I started to accept it, and everything was fine. I did my 3 weeks follow up. Dr. Shah told me everything's looking good, everything's looking fine. guess what? You can start having sex. So I go home and have sex with my wife. She was not having. She still felt like, you know, you're not right. You're not natural. It's not going to feel right. It's not going to feel natural and everything. And I had to just, try to explain things to her. Well, eventually we had sex. And she was expecting, well, you have an implant. You're going to have all these parts hanging from you. I can tell you, unless you tell someone you have an implant, they'll never know. They will never know. There's nothing hanging outside of you. There's nothing protruding from your body. I mean, now it's been almost a year, not quite a year since I've had my implant. Whereas before my prostate cancer, I was having sex with my wife 2 to 3 times a week. After I had my surgery, there was no sex whatsoever. After I had my implant, we're back to 2 to 3 times a week, all weekend. I mean, and to me, it's a great experience. It's one of the best things. If I could have done this when I was 30 years old, I definitely would have done it. I talked to a lot of people. Like I said, I'm one of the patient educators with Dr. Shah's office. So once you have your procedure, I'll probably be talking to you afterward. And I form a very intimate relationship with all of the Dr. Shah's patients. I call you, make sure if there's any swelling, are there any pain, are there anything. I'm going to stay with you the whole time. And I was just telling Dr. Shah earlier about one of the patients that he is now a patient educator. He was very skeptical about having this surgery. He was just scared, totally scared out of his mind. And I stayed with him. I talked to him on a weekly basis. On the day of his procedure, we prayed together. He had the surgery. He called me after the procedure. We're very close. Right now, we're very close. We talk on a regular basis. And it's excellent. If you're worried about the procedure, I mean, I can tell you, I can talk to you from experience. It's not as bad as everyone thinks it is. Trust me on this. And like I said, if you have any questions, I will be there to talk to you. You can call me anytime. I don't care. 2, 3 o'clock at night, it doesn't matter. I don't care. If you want to talk, if you're having an issue, call me. We'll discuss it. And if I can't answer your question for you, I promise you that Dr. Shah or someone in his office can. Someone asked the question earlier about waiting in the doctor's office. I can honestly say this from experience. Dr. Shah's staff, very professional, very professional. I like them. I love them. I go to them. I don't have no problem. If you do have to wait, they'll come out and tell you, Mr. Godfrey, you have to wait, so and so, there's been an emergency or so forth. But they're very open with you. They're very honest with you, and they keep you informed of everything. I love his staff. I thank God for Dr. Shah, because without him, I'd probably be divorced. But this implant is it's life saving. It's relationship saving. It's very and I will recommend it to anybody. Like I said, if I could have had this when I was 35 years old, I probably would have. And I think Dr. Shah mentioned that once you with the implant, you can leave it inflated. Now, when me and my wife have sex, I don't even deflate it. I just keep it up. I let it stay inflated. If she wakes up in the middle of the night and she want to have sex again, she don't have to say nothing to me. She just go to work. And I love it. I wouldn't give anything for it. Like I said, I wish I could have done this 20 years ago. It would have been great. But now I have it. It's a great experience. It will definitely save relationships. And it's psychological also. It's a great motivator for a lot of people. It motivates people to have relationships. It keep you having relationships. And if it would definitely help. Like I said, if you have any questions on a personal matter that you feel is too intimate or too personal to ask right now, please give me a call. My number is on the phone, on the board, 678-983-9515. If you called and I don't answer it, please leave a voicemail, and I promise to get back with you within an hour or 2 hours. I promise you that. But that's all I have from my experience. I'm turning back over to Dr. Shah in case anybody have any more questions.
Thank you, Richard. I would encourage you not to call Richard at 2 a.m. in the morning. He's one of the few guys that'll actually answer his phone, but I certainly would prefer he get some rest so he can help more people in the morning. If you ever have any concerns or questions, we do have an on-call team. You can always reach out to them. If you have one of those priapisms or erections that won't go down, then certainly we have a team you can reach out to. And I always, if it's my patient and they have an issue, I get them into my office right away. Okay, I mean, I will always make time for you. If you need to come in my office 15 times in a week, we'll get you in 15 times in a week. Richard, thank you so much for the testimonial. I'll tell you, it's not easy to talk about your personal life. It's not easy to go to see a physician and talk about your personal life. And it's certainly not easy to openly share with, 40, 50 people, on a webinar like this. So I really appreciate it. Richard's a great guy. He really is a great contact. He's very honest. He'll fill you in on what's going on, but he also helps you through some of the training process. And he's been a great resource for a lot of patients. Both patients that want to consider surgery as well as patients that have had surgery and just have questions about what they're going through. So I'll go through a couple more questions here. It says, what if a patient is on Uroxetrol or Flomax? Should the patient use both treatments and the medication mentioned above, and then does the procedure replace Flomax or Uroxetrol? So Flomax and Uroxetrol are treatments not for erectile dysfunction, but for enlarged prostate. There is some degree of side effect overlap between these medications, as well as PDE5 inhibitors like Viagra, Cialis, Levitra, Stendra. So sometimes, if you take them both, you can get lightheaded. Because they both dilate blood vessels. And so I typically recommend, if you're going to take them, take the Flomax or Uroxetrol in the morning, and then, most people use the medications, the PDE5 inhibitors at night. So try to space them out. You can use them, both. It's not that big of a deal. But if you start getting lightheaded, either space them out or just, don't take the PDE5 inhibitors and consider one of the other treatment options. Can a female go over 50 on her level? So I think someone asked me that. I'm guessing they're talking about testosterone levels. Yeah, you can go over 50, not too much over 50, because then you're going to start getting, facial hair and acne and things like that, and aggression. So, and we can talk more about testosterone. Certainly, if you want to schedule a visit, I'm happy to go in detail on this stuff. I generally, at my visits, I tend to probably talk more than necessary and really try to get you to understand the physiology of everything that your body's going through. So, I think those things are important. It's important to understand what's going on. And, just like these talks, I think these talks are important because they really give you an idea of what could be going on with your body. And we have a lot of diagnostic testing we can do to help answer a lot of your questions. The last thing I'd like to say is, I just want to tell you a little bit about advanced urology as a whole. I'll tell you, this is just an awesome group of physicians and nurse practitioners and physician assistants. I'll tell you, this is one of the only groups I've ever seen that, not only, but one of the groups that really cares about their patients. They care about the outcomes, and we really strive to give you the latest and greatest, but also what's really best for you. We have specialists from all aspects of urology, including men's health and erectile dysfunction treatment. We have several of us out there. There's Dr. Dave over on the west. There's myself, that covers most of the east. We have reconstruction doctors like Dr. Chi up in Lawrenceville. And so we have doctors all over the place that are experts at what we do. And so you're in good hands with us. And when any one of our physicians feel like you have a condition that's too complex, then they'll always get you to the expert that can take care of you the best. And that's what I love about this group, okay? So no matter who you see at Advanced Urology, you're going to be in phenomenal hands. A little bit about myself, I was trained to do these surgeries, the prosthetic surgeries, men's health, complex Peyronie's diseases and bends and things like that. This is what we do. I'll tell you, the majority of urologists do 10 or less of these a year. They're less than 1% of urologists do 100 or more of these. And really, it is an honor to be able to say that I do a lot of these, and I'm a center of excellence. And there are only 2 center of excellences for this surgery in the entire state of Georgia. So it's an honor to say that I have that. I'm also the only center of excellence that I know about in the state of Georgia that is also a center of excellence for BPH and UroLift. So I mean, you're in good hands for all men's health issues. I'm passionate about what I do, and I really, really, really care about outcomes. So if there's ever an issue, we will address it together, and we'll make sure that you come out on top. I do work with the VA in the sense that a large number of my patients are veterans, particularly being in Decatur. That's important, and I've treated a lot of veterans with erectile dysfunction as well. If you don't have any other questions, and I think I answered all of them, you can always reach out to us. You feel free to make an appointment whenever you want. If not with me, with any one of our excellent advanced urology doctors. And we look forward to working with you. I think a lot of you are already seeing some of my partners, and that's great. And if you ever want to see me, certainly reach out. I'd love to see you. I'd love to talk to you and kind of help with any kind of issues that you have. All right, I think that's about it. Thank you again, Richard. I appreciate it, and thank you guys for attending.
Thank you, sir.